Yes.
or dance.
Yeah, especially Capri pizza. I tried
Capri
it.
pizza. Yeah, you know.
Yeah, I know it.
Okay.
Nice to meet you again, sir. The talk of Professor Porcellini will be about pectoralis minor transfer. Welcome, sir. You can start, sir.
I think that is very useful for the young surgeon to know sometimes is impossible to suture the calf, not only for the quality of the tissues, but for the good muscle unit, not only the tendon, but the muscle and the function of the rotator cuff tendon. So I try to explain and to convince the Egyptian colleague about this technique. I published my experience 7 years ago in the Shoulder and Elbow Surgeon journal about this technique for irreparable anterosuperior cuff tear. It's very important to select the patient. What does it mean? It's important the selection, the indication in painful patient resistant to non-operative management with irreparable supraspinatus anterosuperior subscapularis tear with or without pseudoparalysis. For the shoulder surgeons, the knowledge of subscapularis is very important. It's the strongest muscle of the calf, and the anatomy, the subscapularis has 2 parts, and the lower subscapularis has a significant higher muscular activity, especially in elevation and like a humeral head depressor, and of course during anterior instability is very important anterior stabilizer. So I want to identify the right patient for the right indication. Full range of motion, eventually pseudoparalysis, positive beer hug test, positive job test, positive belly press test, and positive Gerber test. So the clinical tests of subscapularis are positive. But please pay attention to the drawing of the left, because everybody knows the balance of the calf for a good activity of the shoulder. But if you consider teres minor, infraspinatus, sovraspinatus, and not one muscle, but superior and inferior subscapularis. Colin described very well the balance to avoid a pseudo-paralysis of the arm and the shoulder. But I think that it's very important, this sagittal view of glenoid, to identify the irreparable superior part of subscapularis, because for indication of this technique is very important to have inferior part of the muscle of low subscapularis good. What about this technique? Charles Rockwood, the father of shoulder pathology and surgery, described similar technique but not the same, for transfer of pectoralis minor, but with the long head of biceps, with conjoint tendon, and it was very difficult to transfer with a good elongation the conjoint tendon. So our idea is to transfer only pectoralis minor to shift pectoral minus under the conjoint tendon. And if you can see, you consider the vector of pectoral minor in the same way of superior part of subscapularis. So the technique is very simple. You detach a small chip of the bone in the medial part of coracoid without damage of pectoral minor, and you shift in the superior part of the insertion of subscapularis, of course, the lesser tuberosity. The lesser tuberosity is very wide, is very large, and you can see in the picture of the right, the inferior part is very clear, but is very, very retracted, the superior part with the neck, with the nuded, the superior part of lesser tuberosity. So the idea, I think, is a good idea, because I go on with the technique, and for me, in selective patient, has a good results, because you have an advantage of bone chip, is very simple suture, and is possible to length the graft. You can see the video, Mohammed, is very clear.
It's quite clear, sir.
So the first step is to detach with the osteotome the bone chip with the minor, pectoral minor, okay? Second step is identify the pedicle and to have a good elongation, of course, in the deep surface, you can see a plexus. So you pass under the conjoint tendon, and this is the final results. So you have inferior part, of course, intact, and superior part with the transfer of the pectoral minor. In the drawing on the right is, I try to to highlight the technique. So what about the rehabilitation? Abduction sling for 6 weeks, patient range of motion at 5 weeks, external rotation at 6 weeks. I trust in shoulder and elbow. I work together with my physiotherapist, and I have a possibility to use the swimming pool. I usually in instability, rotator cuff, prosthesis. For me, it's very important to begin active motion in the swimming pool in this technique at 8 weeks. And now in the paper, I describe the follow-up of 2 years, but now I have follow-up of 7 years. But what about the clinical test after this technique? Pseudoparalysis recovered. In some cases, not in all cases, belly pressed recover 12 on 21. And lift-off test is very difficult, 8 on 21 clinical tests. So the patient are happy, but the clinical test, not all recover in the right manner. Active forward flexion improved by 50 degrees. The constant score improved by 41 points, and simple shoulder test score by 5 points. The patient are happy about the pain, of course. What about complication? In every technique, you can have a complication, of course, very easy in the learning curve. So we have 2 cases of stiffness, probably the tension and the balance of soft tissues was in 2 cases not in a good condition. 1 case of coracoid fracture. Is very important to have a bone chip, because if you use osteotome in the middle, you can have fracture of coracoid. Transfer of pectoral minor, in our experience, is effective. I try to use this technique in arthroscopy technique, but I of course use the arthroscopy technique in every field of instability of rotator cuff. But in this case, I think that open surgery in my hands is a good choice. With this technique, the recovery of active forward elevation and abduction is good. Belly press test and lift-off test for subscapularis is not crucial in this patient, but the vector is similar but not the same of subscapularis. It's possible to have elongation, and the elongation doesn't not compromise graft function. The procedure is safe. Of course, I think that for shoulder surgeon is not a problem. The proximity of brachial plexus and nerve and the nerve, musculocutaneous nerve, of course, is very simple in the medial part to identify the musculocutaneous nerve. I identify with the finger in a lot of procedure, very common in Latarjet procedure for instability. When you detach coracoid, is mandatory to feel the axillary nerve and the musculocutaneous nerve. Normally, the contact with the muscle is 5 centimeters longer, and the distance with the tip of coracoid. And is important when you have a transfer not to use a wide approach, is a local transfer, and with the local transfer you can restore a functional repair of the calf. In the last 2 years, you can see this technique. I use double row in some case with transosseous repair with the button, but the concept is the same. And sometimes when you have a very good muscle, a very good tendon, I prefer now double row suture. Thank you for your attention in Saturday Night Fever.
Yeah. Thank you so much, Professor Porcellini, for demonstrating this interesting technique.
Thank you very much.
Thank you. The first question for you, sir, I think you have already mentioned it. It's a question from one of our colleagues, how to avoid injuring of the musculocutaneous nerve.
Yes, it's very important to know the anatomy, because in the learning curve of a young surgeon, for example, for Latarjet, when you detach a tip of coracoid, is important to know the relationship, normally 5 centimeters in the medial part of conjoint tendon. And is important because, of course, when you perform a transfer under the conjoint tendon, you can use a big traction in the musculocutaneous nerve. So it's important not isolated, but to feel with the finger where the anatomy insertion in the conjoint tendon, to avoid a traction and, of course, neurological problems and complications.
Yes, sir. Thank you. Another question, sir, please. If there is a preoperative stiffness of the shoulder, can I do this technique, or I have to overcome the stiffness first?
Excuse me, I don't understand. In the preoperative,
stiffness, shoulder stiffness.
Stiffness.
Can I operate, or I have to overcome this stiffness first?
Very good question, because the stiff in the shoulder rotator cuff, stiffness is a problem in the rotator cuff term. So I prefer the first step, physiotherapy. When the shoulder recover range of motion and, of course, the best period of physiotherapy normal is 6 months. Sometimes I perform this technique with a wide arthrolysis of capsule to avoid a new stiffness in post-operative phase.
Yeah. Do you prefer, sir, to do a combined arthroscopic release of the adhesions followed by this technique, transfer of the teres minor?
Good question. Yes, because in arthrolysis, I prefer arthroscopic, because you can see the posterior part, the inferior part. Is possible to identify the axillary nerve. So it's a good idea to combine this technique, because stiff shoulder, especially posterior part of capsule, is very not easy, but is possible better in arthroscopy. I use a double cannula posterior to identify the inferior part of humeral head to avoid damage of cartilage, because sometimes it's difficult to introduce the scope, and so I try to use double cannula to avoid the strong introduction.
Yeah, thank you so much, sir, for joining us in this night, in this beautiful night with you. It was an interesting talk, and thank you for sharing your very long experience in the shoulder with the Egyptian colleagues. It's a great honor to be with us, sir. Thank you so much. Hoping to see you in the course again, sir.
Please, if you use this technique or you have a similar patient, write me, and I want to know if, because this technique is cheaper, I don't sell nothing, and so if you use the technique just for my pleasure.
Yeah, thank you, sir.
Wow. Ciao
From
Egizio.
all,
Ciao Egitto. Ciao.
Ciao.
from me and all the organizing committee, have a very best wishes for you and a very good night, sir. Thank you so much.
Ciao, ciao, Mohammed. Ciao,
Ciao.
everyone.
Thank you.
Ciao.
Thank you, sir. Ciao. Thank you, sir. Have a nice